You ever get that feeling like when you're trying to learn something super complicated and you just wish you could download it straight to your brain?
Like have some kind of direct knowledge transfer?
Exactly, like hit download and boom, you
Mm,
know it all.
I think we all feel that way sometimes, especially with topics that just feel huge.
Well, that's exactly the kind of experience we're aiming for on the deep dive, making complex topics accessible and digestible just for you, the learner.
And today we're taking a deep dive into central nervous system conditions and the medications used to manage them.
Yeah, we're talking conditions like schizophrenia, epilepsy, Parkinson's, Alzheimer's, depression, bipolar disorder, the whole spectrum.
It's a fascinating area, but as one of our sources put it pretty bluntly, understanding how these conditions work and how the medications actually do their thing can sometimes feel like, well, like no one really knows what's going on.
Right. It's definitely intricate territory, but we got some excellent resources to guide us through this deep dive.
We're working with a detailed audio lecture designed for medical professionals preparing for their board exams.
So we know it's going to be thorough.
It is. And to complement that, we also have a really clear and concise PDF summary of some key CNS conditions.
So that'll help us keep things organized.
Exactly. It gives us both the in-depth explanations and a nice structured framework.
So what's our mission for today's deep dive?
Well, our goal is to give you, the learner, a clear and manageable understanding of these CNS conditions and the medications used to treat them.
Without getting lost in the weeds.
Absolutely. We're going to focus on the essential stuff, the underlying neurotransmitter imbalances, and the general mechanisms of action of these medications.
The what and the how of it all.
Right. And we'll do our best to avoid getting bogged down in excessive detail because, as our sources point out, much of what we know about the brain and how these conditions work is still evolving.
It's a lot of probability rather than absolute certainty.
Exactly. So we're going to focus on the core concepts and the practical takeaways for you.
All right, let's dive right in, shall we?
Mm-hmm.
And where better to start than with schizophrenia?
So schizophrenia is a chronic psychotic disorder. It's a long-term condition that affects a person's thoughts, perceptions, and behavior. It's characterized by these sort of three core symptom clusters. We have positive symptoms, negative symptoms, and cognitive symptoms.
Oh, wow. Okay, break that down for me.
So positive symptoms, those are things that are added on to a person's experience, like hallucinations, delusions, and disorganized thinking.
Hallucinations I get, that's like seeing or hearing things that aren't really there.
Right, and delusions are these really strong beliefs that are not based in reality, no matter how much evidence you present to the contrary.
Okay, so then negative symptoms, what are those?
These are more about a decrease or absence of normal emotional responses and behaviors.
So like,
Like a flat affect, where someone shows very little emotion, or alogia, which is a poverty of speech.
makes sense. And cognitive symptoms.
Those affect things like memory, attention, and executive function, basically the brain's ability to plan, organize, and make decisions.
Gotcha. So it's like a trifecta of challenges affecting a person on multiple levels.
It really is. And one of the things that makes schizophrenia so difficult to grapple with is that it often emerges in late adolescence or early adulthood.
So during a crucial time of development and transition.
Exactly. When people are typically figuring out who they are, what they want to do with their lives, it can be incredibly disruptive.
And you mentioned earlier that schizophrenia affects about 1% of the population.
That's right. It's actually more common than many people realize.
Wow, that's actually quite a significant number when you think about it.
It is. And it really highlights the importance of understanding this condition and the challenges faced by individuals and families affected by it.
Now, one of the things that really struck me from our audio source was this image of fireworks going off inside the brain to describe what might be happening with dopamine and schizophrenia. Could you elaborate on that a bit?
Yeah, that's a really vivid analogy, isn't it? It helps to visualize what might be happening at a neurochemical level. So, the dopamine hypothesis of schizophrenia suggests that an excess of dopamine activity in certain parts of the brain plays a key role in the development of symptoms.
An excess of dopamine.
Hmm.
So too much of a good thing.
In a way, yes, dopamine is a neurotransmitter. It's a chemical messenger in the brain, and it's involved in a whole bunch of important functions like movement, motivation, reward pleasure, and even things like attention and learning.
So there's too much dopamine. Wouldn't that make you feel really good, really happy all the time?
You might think so, but it's actually a lot more complex than that. The dopamine hypothesis focuses on an imbalance of dopamine activity in specific brain regions, particularly the mesolimbic pathway.
The what pathway?
The mesolimbic pathway. It's basically the brain's reward pathway, and it plays a role in things like motivation, pleasure, and reinforcement.
So too much dopamine in this pathway could explain some of the positive symptoms of schizophrenia, like hallucinations and delusions.
That's the idea. An overactive reward system might lead to misinterpretations of sensory information and unusual thoughts and beliefs.
I see. So how do the medications for schizophrenia actually work to address this dopamine imbalance?
Well, many of the antipsychotic medications used to treat schizophrenia work by blocking dopamine receptors in the brain.
Blocking them so dopamine can't bind and exert its effects.
Precisely. They essentially dampen down the activity of dopamine, particularly in that mesolimbic pathway.
And is that effective?
Yes, for many people, antipsychotics can be very effective in reducing the severity of positive symptoms like hallucinations and delusions.
That makes sense. So it's like turning down the volume on those fireworks going off in the brain.
That's a good way to put it. And the audio source mentioned that these medications specifically target a subtype of dopamine receptors called D2 receptors.
Two receptors.
Right. The D2 receptors are particularly concentrated in those brain regions associated with the symptoms of schizophrenia.
And are all antipsychotic medications the same in how they target these receptors?
Well, that's a great question, and it leads us to an important distinction between the different types of antipsychotic medications.
Okay, wait on me.
So we have the older or first-generation antipsychotics, often referred to as typical antipsychotics, and then we have the newer or second-generation antipsychotics, often called atypical antipsychotics.
Typical versus atypical. What's the difference?
The main difference lies in their mechanism of action and their side effect profiles.
You mentioned side effects earlier.
Yeah.
So the newer atypical antipsychotics tend to have fewer side effects.
In general, yes. That's one of their major advantages.
But what about their mechanism of action? How do they actually work differently?
So the typical antipsychotics primarily target those D2 dopamine receptors I mentioned earlier. They block these receptors pretty potently, which can be effective in reducing positive symptoms. But it can also lead to some unwanted side effects, particularly movement-related side effects,
Movement-related side effects like what?
like extrapyramidal symptoms, or EPS for short.
EPS.
Yeah, EPS can include things like tremors, stiffness, restlessness, and even these involuntary movements called tardive dyskinesia.
Tardive dyskinesia.
That sounds serious.
It can be. It involves these repetitive involuntary movements of the face, tongue, and limbs, and it can be really distressing for people who experience it.
So that's a significant downside of the typical antipsychotics.
It is, and it's one of the reasons why the development of the atypical antipsychotics was such a big deal.
So how are the atypicals different?
Well, they still block dopamine receptors, but they also have a stronger affinity for serotonin receptors, particularly a subtype called 5-HT2A receptors.
Serotonin receptors, so they're hitting two neurotransmitter systems at once.
Exactly. And this dual action seems to give them a better side effect profile. They're less likely to cause those extrapyramidal symptoms, and they might even be better at addressing some of the negative symptoms of schizophrenia.
Interesting. So the atypical antipsychotics are like a more refined approach. You could say that they're trying to target the dopamine system in a more nuanced way and also modulate serotonin, which seems to play a role in mood cognition and social behavior.
It's all about finding that right balance, isn't it?
Exactly. Striking that balance between effectiveness and tolerability.
So what are some examples of these typical and atypical antipsychotics?
Well, for the typical antipsychotics, you might recognize names like haloperidol or drugs ending in acene like chlorpromazine, fluphenazine.
Okay, those ring a bell.
And for the atypical antipsychotics, some of the common ones are clozapine, risperidone, olanzapine, quetiapine, or aripiprazole.
Wow, quite a list. There's been a lot of progress in developing these medications over the years, hasn't there?
Definitely. And while the atypicals generally have a better side effect profile, there's no one-size-fits-all antipsychotic.
Reading.
What works well for one person might not work as well for another. And each medication comes with its own potential side effects. So it's really important to work closely with a healthcare professional to find the best treatment plan for each individual.
Makes sense. Now, our audio source mentions something about these medications affecting other receptor systems in the body besides dopamine and serotonin. Could you explain that a bit more?
Yeah, so antipsychotic medications, especially the typical ones, can interact with other neurotransmitter receptors besides just dopamine and serotonin. This can lead to a range of side effects.
Oh boy, like what?
Well, one example is their effects on cholinergic receptors.
Cholinergic receptors, what do those do?
They're involved in a variety of functions, including muscle control, memory, and learning.
Okay.
So when antipsychotics block these receptors, it can lead to side effects like dry mouth, blurred vision, constipation, and difficulty urinating.
Makes sense if they're involved in muscle control.
Right. And then there's the adrenergic receptors.
Adrenergic, those sound familiar.
They're part of the sympathetic nervous system, which is responsible for the fight or flight response.
Okay, so what happens when antipsychotics mess with those?
Well, blocking adrenergic receptors can cause things like orthostatic hypotension, which is that feeling of lightheadedness or dizziness when you stand up too quickly.
Oh yeah, I've experienced that before. It's not fun.
Not at all. It can also cause drowsiness and even reflex tachycardia, which is a rapid heartbeat.
And didn't the audio source mention something about histaminergic receptors too?
Yes, histaminergic receptors are involved in things like wakefulness, appetite, and inflammation,
So blocking those could cause...
drowsiness, weight gain, and even some allergic reactions.
Wow, so it's like a domino effect. One thing leads to another.
It really can be. And it highlights the complexity of these medications and why careful monitoring and management of side effects is so crucial.
Now, speaking of side effects, there was this one peculiar exception that our audio source pointed out regarding clozapine. Instead of causing dry mouth, like many of these medications, it can actually increase salivation. That seemed like a pretty unusual detail.
It is unusual, and it really speaks to the complex pharmacology of clozapine. It's actually one of the most effective antipsychotic medications, especially for people who haven't responded well to other treatments.
So it's a powerful drug.
It is, but it also comes with a higher risk of serious side effects, like agranulocytosis, which is a dangerous drop in white blood cell count.
Oh, wow. So it's definitely a high-risk, high-reward kind of medication.
Exactly. It's not typically a first-line treatment.
Yeah.
But for those who've tried other antipsychotics without success, clozapine can be a real game changer.
And back to that salivation thing. Any idea why it has that opposite effect?
Well, the exact mechanisms are still being investigated, but it might have to do with clozapine's unique receptor profile. It binds to a wide range of receptors, including muscarinic receptors, which are involved in salivation.
Ah, so it might actually stimulate those receptors instead of blocking them.
That's one possibility. And it just goes to show that even with medications we've been using for a long time, there's still a lot we don't fully understand.
Always more to learn. So the key takeaway regarding medications for schizophrenia is that they're primarily focused on managing symptoms, not curing the condition itself.
That's a crucial point to remember. These medications can significantly improve quality of life for individuals with schizophrenia by reducing the severity of their symptoms.
Like those hallucinations, delusions, and disorganized thinking.
Right, but they don't address the underlying cause of the disorder, which is still not fully understood.
So it's about managing rather than curing.
Exactly. And ongoing research is constantly seeking to develop new and more effective treatments for schizophrenia with fewer side effects.
Hopefully someday we'll have even better options. All right, let's move on to our next topic, epilepsy.
Okay, so epilepsy.
Epilepsy.
Epilepsy is a neurological disorder that's characterized by recurrent seizures.
Seizures. So those sudden, uncontrolled bursts of electrical activity in the brain?
Precisely. And our audio source had a really helpful analogy comparing the brain to a complex network of wires and traffic signals. In epilepsy, it's like there's a traffic light shorting out, causing a surge of electrical activity that disrupts the normal flow of information.
I like that analogy. It really helps to picture what's going on.
Right, so instead of a smooth flow of traffic, you get this chaotic surge.
And that leads to the various symptoms we associate with seizures.
Exactly. The symptoms of a seizure can vary widely depending on where in the brain the electrical disturbance originates and how much of the brain it involves.
So it's not just the classic convulsive seizure where someone falls to the ground and their body shakes uncontrollably.
Right. There are many different types of seizures. Some people might just experience a brief lapse in awareness or a strange sensation, while others might have more pronounced motor symptoms like jerking movements or loss of muscle control.
So how do we categorize these different types of seizures?
Well, one of the main distinctions is between focal seizures and generalized seizures.
Focal versus generalized. Break it down for me.
So focal seizures originate in a specific area of the brain. They used to be called partial seizures.
I've heard that term before.
Yeah, it's an older term, but you might still come across it. Focal seizures can cause a variety of symptoms depending on which part of the brain is affected.
So like,
If the seizure starts in the motor cortex, which controls movement, you might see twitching or jerking in a specific limb.
okay.
But if it originates in the temporal lobe, which is involved in memory and emotion, someone might experience strange sensations, feelings of déjà vu, or even hallucinations.
Interesting. So focal seizures can be pretty diverse in how they present.
They can. And then we have generalized seizures.
Those are the ones that involve the whole brain.
Exactly. They typically cause a loss of consciousness and can involve a variety of motor symptoms like stiffening of the body, jerking movements, or even complete loss of muscle tone.
So that's where we get the classic grand mal seizure image from.
Right. The grand mal seizure, which is now called a generalized tonic-clonic seizure, is a type of generalized seizure.
So lots of different ways a seizure can manifest depending on where it starts and how much of the brain it involves.
Absolutely. And understanding these different types of seizures is crucial for determining the best treatment approach.
So let's talk about treatment. How do medications actually work to control seizures?
Well, the goal of anti-seizure medications is to try to prevent those abnormal surges of electrical activity in the brain.
Okay, but how do they actually do that?
There are a few main mechanisms of action. Some target neurotransmitters, while others focus on ion channels.
Okay, remind me what neurotransmitters are again.
They're the chemical messengers in the brain that allow neurons to communicate with each other.
Right, and ion channels.
Ion channels are like these tiny gates in the cell membranes of neurons. They control the flow of ions like sodium, potassium, and calcium in and out of the cell.
And this flow of ions is what generates the electrical signals in the brain.
Exactly. So some anti-seizure medications work by modulating these ion channels to try to stabilize the electrical activity of neurons.
So it's like putting a safety valve on those surges.
That's a good analogy. Now let's delve into some specific medication examples.
Let's do it. The audio source mentioned sodium channel blockers like phenytoin and carbamazepine. How do those work?
So sodium channels are really important for the initiation and propagation of action potentials, which are the electrical signals that travel along neurons.
Okay.
And when a neuron fires an action potential, there's a rapid influx of sodium ions through these sodium channels.
Sodium channel blockers essentially block this influx of sodium.
Exactly. And by doing that, they can help to prevent the rapid repetitive firing of neurons that's characteristic of seizures.
So it's like slowing down the electrical storm.
That's a good way to think about it.
Yeah.
And both phenytoin and carbamazepine are effective against a variety of seizure types, including focal seizures and generalized tonic-clonic seizures.
And the PDF mentioned that carbamazepine is also used for trigeminal neuralgia. What's that?
Trigeminal neuralgia is a really painful condition that affects the trigeminal nerve, which is one of the nerves that supplies sensation to the face. It causes these sudden, intense episodes of stabbing or electric shock-like pain.
Wow, that sounds awful.
It is, and carbamazepine can be really helpful in managing that pain.
Interesting. So it has multiple uses.
It does, and the audio source also highlighted that it can be used for bipolar disorder.
Oh, really? So it's not just for seizures?
Not just for seizures, it seems to have mood-stabilizing properties as well.
Okay, but there were also some cautions mentioned about carbamazepine.
Right. It's important to note that carbamazepine can interact with a lot of other medications.
Because
It's an enzyme inducer, meaning it can speed up the metabolism of certain drugs, making them less effective.
so it can interfere with other treatment.
It can. And the PDF also mentioned a risk of hyponatremia, which is low sodium levels in the blood, particularly in older adults.
So that's something to watch out for.
Definitely. And another important point is that carbamazepine is not typically used for absent seizures.
Absent seizures.
Yeah, they used to be called petit mal seizures.
I've heard that term.
It's another older term. But absent seizures are characterized by brief lapses in awareness, often just a few seconds, where the person seems to stare blankly and might not respond to their surroundings.
And carbamazepine can actually worsen those.
It can, unfortunately.
Okay, so it's not a universal anti-seizure medication.
No, it's not. And that's why a careful diagnosis and understanding of the specific seizure type is crucial for selecting the right treatment.
And what about phenytoin? Any particular things to note about that one?
Well, phenytoin is also a sodium channel blocker, and it's been used for decades to treat various types of seizures. But one side effect that the audio lecture emphasized, and that's especially relevant for dental professionals, is gingival hyperplasia.
Gingival hyperplasia meaning...
It's an overgrowth of gum tissue.
Oh, so it can cause your gums to basically swell up?
Yeah, basically. It's a fairly common side effect of phenytoin, and it can be quite bothersome. It can make it harder to brush and floss properly, and it can even affect the alignment of teeth in some cases.
Not ideal. So dentists need to be aware of this potential side effect in patients taking phenytoin.
Absolutely. It highlights the importance of communication between healthcare providers.
Right, making sure everyone is on the same page about a patient's medications and potential side effects. Now, besides sodium channel blockers, our audio source also mentioned benzodiazepines, like lorazepam and diazepam. How do those fit into the picture?
Benzodiazepines are another class of medications that can be used to treat seizures. They work by enhancing the effects of GABA, which is the main inhibitory neurotransmitter in the brain.
Inhibitory meaning.
It helps to calm down or inhibit neuronal activity.
So GABA is like the brakes in the brain.
That's a good analogy, and benzodiazepines essentially make those brakes more powerful.
So they help to dampen down the excessive electrical activity that causes seizures.
Exactly. Now, most benzodiazepines are used for acute seizure management,
Acute meaning.
like in emergency situations such as status epilepticus.
Status epilepticus. That sounds serious.
It's basically a prolonged seizure that doesn't stop on its own, or a series of seizures that occur close together without the person regaining consciousness in between.
Oh, wow. So it's like a continuous seizure state.
Exactly. It's a medical emergency that requires prompt treatment.
And benzodiazepines are the go-to medication in those situations.
Often, yes. They can be given intravenously or rectally for rapid control of seizures.
And our PDF source mentioned clonazepam and clobazam as examples of benzodiazepines that can be used as adjunctive therapy. What does that mean?
Adjunctive therapy means they're used in combination with other anti-seizure medications.
So like an add-on treatment.
Right. They're not typically used as the sole treatment for epilepsy, but they can be added to a person's regimen if their seizures aren't fully controlled with other medications.
Okay, so benzodiazepines have a couple of different roles in epilepsy management, both for acute emergencies and as an add-on treatment.
That's right. Now let's talk about a medication called felbamate.
Felbamate.
Yeah, the audio source described it as having a really broad spectrum of activity.
Broad spectrum meaning.
It works on multiple targets in the brain. It affects sodium channels, glutamate receptors, calcium channels, and it also enhances GABAergic transmission.
Wow, so it's hitting a lot of different pathways.
It is. And while this broad activity can make it effective in treating some really difficult to control seizures, it also comes with a higher risk of serious side effects.
The audio source specifically mentioned aplastic anemia and liver failure.
Right. Those are very serious and potentially life-threatening side effects.
So it's a powerful drug, but it needs to be used with extreme caution.
Absolutely. Felbamate is typically reserved for those with severe refractory epilepsy, meaning people who haven't responded well to other anti-seizure medications.
Makes sense. High risk, high reward.
Thanks.
Okay, now there was another medication that the audio source called a bit of a mystery, gabapentin. You called it a GABA analog mystery earlier.
It really is. It's structurally similar to GABA, meaning it has a similar chemical makeup. But unlike benzodiazepines, it doesn't actually bind to GABA receptors.
So if it's not acting on GABA receptors, how does it work?
Well, that's the mystery part. Its exact mechanism of action isn't fully understood.
Oh, wow. So we're using a drug and we're not even entirely sure how it works.
That might sound surprising, but it actually happens more often than you might think.
Oh, really?
Yeah, sometimes we discover a drug's therapeutic effects before we fully understand its underlying mechanism.
Through observation in clinical trials?
Exactly. And that's the case with gabapentin. We know it's effective for treating certain types of seizures and for managing nerve pain, like postherpetic neuralgia.
Okay, but how it actually does that remains a bit of an enigma.
It does. But despite the mystery surrounding its mechanism, gabapentin is generally well tolerated and has a favorable side effect profile.
And the PDF highlighted that it's particularly well suited for older patients.
Right.
Why is that?
Well, one of the advantages of gabapentin is that it's not metabolized by the liver. It's primarily excreted unchanged by the kidneys.
So
It's less likely to interact with other medications, which is particularly important for older adults who are often taking multiple drugs.
yeah, that makes a lot of sense, minimizing the risk of those drug interactions.
Yeah.
Then there was another medication mentioned in a similar context, pregabalin.
Yes, pregabalin is similar to gabapentin in its uses and side effects, but it does have a more defined mechanism of action.
Meaning?
We know more about how it works. Pregabalin binds to a specific subunit of voltage-gated calcium channels.
Voltage-gated calcium channels. Remind me what those are.
So calcium channels are involved in the release of neurotransmitters from neurons.
Okay.
And voltage-gated means they open and close in response to changes in the electrical potential across the cell membrane.
Gotcha. So by binding to these calcium channels, pregabalin can modulate the release of neurotransmitters.
Exactly. It specifically inhibits the release of excitatory neurotransmitters like glutamate and substance P.
Those are the ones that ramp up neuronal activity.
Right. And by reducing their release, pregabalin can help to calm down the overexcitation that leads to seizures and nerve pain.
So it's like turning down the volume on those excitatory signals.
That's a good way to think about it. Pregabalin is used for a variety of conditions, including focal seizures, neuropathic pain, postherpetic neuralgia, and even fibromyalgia.
Wow, so it has a pretty broad range of applications.
It does, and like gabapentin, it's mainly eliminated by the kidneys, so it's generally well tolerated in older adults and has fewer drug interactions.
Always a good thing.
Yeah.
Especially for those who might be on multiple medications already.
Definitely. The PDF did mention a couple of potential side effects, though: weight gain and peripheral edema.
Peripheral edema that's swelling in the legs and feet, right?
Right. It's a buildup of fluid in the tissues, and it can happen with pregabalin, especially at higher doses.
So something to keep an eye on.
Yeah.
Okay, now onto the last medication for epilepsy. That our audio source covered valproic acid, or as they called it, the Joker.
The Joker.
Yeah, they made it sound like this drug is a bit of a wild card. What's behind that nickname?
Well, I think the nickname comes from valproic acid's versatility. It has multiple mechanisms of action. It can block sodium channels, enhance GABAergic transmission, and affect calcium channels.
So it's a triple threat.
You could say that this multi-pronged approach makes it effective against a wide variety of seizure types, both focal and generalized.
So it's like a jack of all trades.
Exactly. It's often a valuable option for people with difficult-to-control epilepsy.
But the audio source also mentioned some serious safety concerns.
Yes, unfortunately, valproic acid carries a risk of liver toxicity, and it's also teratogenic, meaning it can cause birth defects if taken during pregnancy.
Oh, wow. So that's a major red flag for women of childbearing age.
It absolutely is. Valproic acid should not be used during pregnancy unless there are no other suitable treatment options and the benefits clearly outweigh the risks.
So it's a powerful medication, but it definitely needs to be used with caution and careful consideration of the potential risks.
Absolutely. Now, one more important point about epilepsy management. Our audio source made sure to define status epilepticus and its initial emergency treatment.
Right, status epilepticus, we talked about that briefly earlier, those prolonged seizures that don't stop on their own.
Exactly. For tonic-clonic seizures, it's defined as a seizure lasting longer than 5 minutes, or for absence seizures lasting longer than 2 minutes.
And that's when those rapidly acting benzodiazepines like lorazepam and diazepam come into play.
They're the first-line treatment for status epilepticus. It's crucial to stop the seizure as quickly as possible to prevent permanent brain damage.
So it's a race against time.
It can be. And that's why it's so important for people with epilepsy and their families to be educated about seizure first aid and to have a plan in place in case of an emergency.
Absolutely. Preparedness is key. So just like with schizophrenia, the primary goal with epilepsy medications is to gain control over seizures, not to cure the underlying predisposition to having them.
Exactly. These medications can dramatically improve the lives of people with epilepsy by reducing the frequency and severity of their seizures, but they don't eliminate the underlying neurological condition.
So it's about managing and living well with epilepsy.
Exactly. And as with any chronic condition, ongoing research is constantly seeking to develop new and more effective treatments with fewer side effects.
Hopefully someday we'll have even better options. Okay, let's move on to our next topic, Parkinson's disease.
All right, so Parkinson's disease.
The audio source started by mentioning Muhammad Ali, the famous boxer who lived with this condition.
He's a great example of someone who lived a full and active life despite facing the challenges of Parkinson's.
Absolutely.
Yeah.
And it really highlights the importance of understanding this condition and the impact it has on people's lives.
So Parkinson's is a neurodegenerative disorder.
Neurodegenerative meaning.
It involves the progressive loss of neurons in the brain.
Okay. And which neurons are specifically affected in Parkinson's?
The neurons that are primarily affected in Parkinson's are those that produce dopamine in a region of the brain called the substantia nigra.
The substantia nigra.
Yeah, it's a tiny little area located in the midbrain, and it plays a crucial role in regulating movement.
So as those dopamine-producing neurons die off, what happens?
Well, dopamine is a key neurotransmitter involved in controlling movement coordination and balance. So when there's a shortage of dopamine in the brain, it leads to the characteristic motor symptoms of Parkinson's.
Those being?
The classic triad of symptoms is tremor, rigidity, and bradykinesia.
Tremor, that's the shaking, right?
Exactly. It's often a resting tremor, meaning it's most noticeable when the person is at rest, and it tends to decrease with voluntary movement.
Okay, and rigidity.
Rigidity refers to stiffness or resistance to movement. It's like the muscles are constantly tense.
And bradykinesia.
Bradykinesia is slowness of movement. It can affect all aspects of movement from walking and talking to simple tasks like buttoning a shirt or brushing your teeth.
Wow, so it can really impact a person's ability to perform everyday activities.
It can. And in addition to those three core motor symptoms, people with Parkinson's can also experience a variety of other issues like postural instability, which is difficulty maintaining balance, problems with gait, or walking autonomic dysfunction, which can affect things like blood pressure and digestion, sleep disturbances, and even cognitive changes.
So it's really multifaceted condition that affects people on many levels.
It is, and it's
Okay.
important to remember that Parkinson's is a progressive disorder, meaning the symptoms tend to worsen over time.
And it commonly affects individuals over the age of 65.
That's right, although it can occur in younger people too.
Now, the audio source mentioned this really interesting concept of an imbalance between dopamine and acetylcholine in the brain in Parkinson's disease. Could you unpack that a bit for us?
Yeah, so acetylcholine is another neurotransmitter that plays a role in movement control, but it has an opposite effect to dopamine.
Meaning?
While dopamine promotes movement, acetylcholine tends to inhibit it.
Okay.
So in Parkinson's, as dopamine levels decline, there is a relative overactivity of the cholinergic system.
So it's like a seesaw. One side goes down, the other side goes up.
Exactly. And this imbalance is thought to contribute significantly to the motor symptoms of Parkinson's.
I see. So the goal of treatment is to try to restore that balance.
That's a big part of it. And one of the primary medications used to manage Parkinson's is levodopa.
Levodopa.
It's actually a precursor to dopamine.
Precursor meaning,
It's a substance that the body converts into dopamine.
oh, okay, so it's like giving the brain the building blocks to make more dopamine.
Exactly. And levodopa can cross the blood-brain barrier, which dopamine itself cannot.
The blood-brain barrier, that's the protective shield that surrounds the brain, right?
Right. It's a semi-permeable barrier that prevents certain substances from entering the brain from the bloodstream.
So levodopa can sneak past this barrier
Yeah.
and then get converted into dopamine once it's inside the brain.
That's the idea. It's a very clever way to replenish dopamine levels.
Ingenious.
Yeah.
But the audio source also mentioned that carbidopa is often given alongside levodopa. Why is that?
That's a really important point. Carbidopa is an enzyme inhibitor.
Meaning?
It blocks the activity of an enzyme called dopa decarboxylase.
And why is that important?
Well, dopa decarboxylase is the enzyme that converts levodopa into dopamine.
Ah, so if you block this enzyme, you prevent levodopa from being converted into dopamine before it reaches the brain.
Exactly. That's the key. Carbidopa acts primarily outside the brain in the peripheral tissues.
So it allows more levodopa to reach the brain where it's needed.
Precisely. It essentially helps to protect levodopa so it can do its job.
That's really smart.
Yeah.
So carbidopa is like levodopa's bodyguard.
I like that analogy. It's a great way to remember how they work together.
Now, the audio source also briefly mentioned COMT inhibitors.
COMT inhibitors are another class of medications that can be used in Parkinson's treatment.
COMT standing for?
Catecholomethyltransferase.
Catchy.
Yeah, it's a mouthful. But COMT is an enzyme that breaks down dopamine and also levodopa.
Oh, so COMT inhibitors would prevent this breakdown.
Exactly. And by doing that, they help to prolong the effects of levodopa.
So it's like giving levodopa an extended lifespan.
That's a good way to put it. Two commonly used COMT inhibitors are in